Welcome back to the deep dive. Today, we are cracking open what is essentially the instruction manual for a physician's brain.
That's a great way to put it.
Our mission is to understand probably the most critical skill in medicine, but one that's, not always taught so formally, clinical decision making.
Exactly. And we're pulling this straight from Davidson's medicine.
Yeah.
For all of you listening who are maybe first or second year med students, you're just drowning in facts right now.
Right. Anatomy, physiology, all of it.
All of it. But that knowledge is just, well, it's inert until you know how to use it. And Davidson makes the point that this process, clinical reasoning, is the #1 skill for a 21st century doctor, more than just knowing facts.
I love that idea. So if all that knowledge, the pharmacology, the diseases, if that's all the software, what is clinical reasoning?
Clinical reasoning is the physician's operating system, the OS.
The OS? Okay.
It's the whole thinking process, the structure that takes your knowledge, your communication skills, your ethics, and integrates them into actual clinical practice. Without a good OS, the best software in the world just crashes.
And when the OS crashes in medicine, the consequences are, well, they're severe. Which brings us right to the stakes here. The problem of diagnostic error.
It's incredibly sobering. Studies show that in key areas, like the emergency department, internal medicine, the diagnosis is wrong something like 10 to 15% of the time.
1 in 10. That is a staggering number.
It is. And what's worse is that diagnostic error is linked to more patient harm, more morbidity than other types of medical errors. And the majority of them are preventable.
Preventable. So we have to understand why they happen. Davidson's breaks the root causes down into 3 big categories.
Right. And understanding these is the only way we can start to fix the problem. The first one is what they call no fault.
No fault. So that's unavoidable.
Pretty much. This is when the disease presents in a really unusual way, or it's so early that the signs just aren't there yet. It's, beyond the control of the clinician or the system. It just happens.
Okay, so that's category 1. What's the second?
The second is system error. This is about the environment. Things like having outdated equipment or lab results not being available when you need them.
Or poor communication between teams.
That's a huge one. Or not enough supervision for junior staff. A doctor who's been working for 30 hours straight and makes a mistake. That's a system failure, not an individual one.
So we have unavoidable errors and system errors, which leaves the third category, which I guess is all about the individual doctor's thinking.
Exactly. The third is human cognitive error. And this is the really tricky one. It's where the clinician has all the information they need, the history, the labs, the scans are all there, but they still reach the wrong conclusion.
So the OS has all the data, but the processing is flawed. Why?
Well, the book points to 3 reasons for this. First and simplest is just knowledge gaps. You don't know a key fact.
That's fixable with study. Read the book.
Right. But the other 2 are much more subtle.
Yeah.
Misinterpretation of diagnostic tests, which we'll get into a lot.
And the big one.
And cognitive biases, those subconscious mental shortcuts that our brains take that lead us completely astray.
And that's really where this deep dive is going to focus. Misinterpretation and bias. Because those are about how we think, not just what we know.
That's the mission today. We're going to unpack this whole OS, starting with the history and physical, then interpreting tests, and finally tackling those cognitive biases head on. It's like a software update for your clinical brain.
Perfect. That sets the stage.
And just before we move on, let's do our first check-in. Check-in 1. The foundation during 1. So for you listening, can you quickly name those 3 main categories of diagnostic error we just covered?
No fault, system, and human.
If those are at all fuzzy for you, just pause and rewind for a second. Anchoring those concepts is really crucial.
All right, let's get into the first step of the OS process, gathering the data, the history and physical examination. With all the tech we have now, fancy CT scanners and genetic tests, it's easy to think the history has become less important. But Davidson's is emphatic about this.
It's unequivocal. The history is still the most important part of the whole process. The data is just so compelling. In 70 to 90% of cases, the diagnosis is made from the history alone.
70 to 90%, that's incredible.
It is. The history is where you get the context, the timeline, the patient's own story. And history is broad. It's the patient, sure, But it's also paramedic notes, eyewitnesses, old records. It's a huge data gathering exercise.
But the book cautions us against just, memorizing lists of symptoms. We have to move to something called evidence-based history and examination, or EBHE. What's that actually mean?
It means we have to stop treating every symptom and every sign as if it has the same weight. It doesn't. You need to understand the diagnostic usefulness of a clinical feature, how much it actually helps you.
So it's about the weight of the evidence.
Exactly. Students learn the classic triad for disease, right?
Yeah.
But what if that triad only shows up in, say, 10% of actual patients? Then it's not a very useful tool, is it?
Let's use that meningitis example from the book. It's such a powerful illustration of this.
It's perfect. So the textbook triad for bacterial meningitis is headache, fever, and meninism. Neck stiffness.
the classic signs. Koenig's and Brudzinski's signs.
Right. But then you look at a big U.S. study, pretty much every patient had a headache and fever. Okay, that's useful. But less than half had neck stiffness.
Yeah.
And only 5% had Koenig's or Brudzinski's.
5%. So if a sign is only there 5% of the time, its absence tells you basically nothing.
It tells you nothing. It's a poor tool, which is where we have to bring in the math. We have to talk about likelihood ratios or LRs.
And LRs, the quantitative measure of that diagnostic weight.
Precisely. They tell you exactly how much of finding a symptom being present or absent changes the probability of a disease.
Let's use that metaphor you mentioned earlier, the diagnostic seesaw.
Okay, perfect. So imagine a seesaw. An LR that's greater than 1 increases the probability of the disease. It pushes that side of the seesaw up towards a diagnosis. And the higher the number, the bigger the push. An LR of 50 is a huge push.
And an LR of less than 1 must push it down.
Exactly. It decreases the probability. So, say the absence of a fever in suspected sepsis might have an LR of 0.2. That's a really significant push away from the diagnosis.
Yeah.
And critically, if a feature has an LR that's close to 1,
Like those meningitis signs.
it's useless. It barely moves the seesaw at all. Its presence or absence doesn't help you make a decision.
So why do those signs have such a low LR if they're so classic?
Because they're only really present in patients with severe inflammation. They miss everyone with mild or early disease. So, as a test to rule the disease out, they're not very good.
Okay, so LRs tell you how much a finding changes things. But, and this feels like the big conceptual leap, they only tell you about the change, not the final probability.
That is the whole game. You cannot use an LR until you first estimate your overall clinical suspicion, what we call the pretest probability.
Which you get from the history, the risk factors, the whole picture.
A whole clinical gestalt. So if your patient is immunosuppressed and has a massive headache and a high fever, your pretest probability for meningitis might already be, say, 95%.
So at that point, testing for Koenig's sign with its LR of close to 1 is pointless.
It's totally pointless. It won't change your decision to act. The pretest probability is the absolute foundation. If you get that starting estimate wrong, every single test or calculation you do after that will be flawed.
The history defines the starting line. Get that wrong and you can't win the race.
That's it, exactly.
Okay, so we've nailed the history and our pretest probability. Now we use the tools to adjust that probability. Diagnostic tests. And the fundamental idea here is a big one. There is no such thing as a perfect diagnostic test.
None. Zero. Every single result has to be interpreted. And there are 5 key factors affecting that interpretation. Let's start with the first one. How we even define what's normal.
Right, the normal range.
And we should stop calling it that. The book is right. The better term is reference range because it's based on statistics.
The bell curve, the Gaussian distribution.
Right. Most results follow that curve. And by convention, the reference range is just the middle 95% of the healthy population.
Which brings us to what you call the 2.5% club.
You have to anchor on this. If the range is 95%, that means 2.5% of perfectly healthy people will have a result above the range, and 2.5% will have one below it.
So 1 in every 20 healthy people will have an abnormal lab result.
1 in 20, just walking around. So an abnormal result does not automatically mean you have a disease. It just means you're a statistical outlier.
But the real difficulty in interpretation comes from the overlap, right?
The overlap is where all the uncertainty in medicine lives. The test results from the sick population often overlap with the results from the healthy population. You can be sick with a normal result or healthy with an abnormal one.
Which brings us to the context rule. This is where normal can be abnormal and abnormal can be normal.
I love this concept because it forces you to think about the physiology. Let's take that severe asthma attack example.
Okay.
The patient is struggling to breathe, they're hyperventilating, Physiologically, they should be blowing off lots of carbon dioxide. Their PaCO2 should be low.
Right.
So if you do a blood gas test and their PaCO2 is in the statistically normal range, that is a terrifying sign.
Why, if it's normal?
Because in that context, normal means their respiratory muscles are exhausted. They're failing. They can't hyperventilate anymore. That normal number signals impending respiratory collapse. It's a life-threatening abnormality.
And the reverse can be true. An abnormal result can be physiologically fine.
The classic one is a low ferritin in a young menstruating woman. Ferritin is iron storage. Technically, a low level is abnormal, but given the context of monthly physiological blood loss, it might be a completely expected finding, not a sign of some major disease. Context is everything.
We also have to deal with just natural variation. My cholesterol today won't be the exact same number as my cholesterol next week.
And that's so important. Results vary day to day because of biology, what you ate, and just random lab variation, which is why we need to understand the critical difference.
The critical difference.
That's the threshold a result has to cross for the change to be considered real and not just random noise. For cholesterol, it's about 17%.
So if a patient's cholesterol goes from 5.0 down to 4.5, that's only a 10% change.
Right, so even if you started on a statin, you can't be confident that drop is because of the drug. It's within the noise. The result has to change by more than 17% for you to say, okay, this is a real physiological change.
That feels like a super common error for junior clinicians to make. Overinterpreting small changes.
All the time.
Okay, moving beyond the stats, there are non-disease factors. The patient's context. Davidson's gives some great examples.
These are the ones you just have to memorize. Age is a huge one. Take creatinine for kidney function. It depends on muscle mass.
And older people have less muscle mass.
Exactly. So a creatinine level that's normal for a 40-year-old might actually be masking terrible kidney function in an 85-year-old. The number is deceptively reassuring.
And ethnicity can play a role too.
Yes. Healthy people of African ancestry can have a naturally lower white cell count. It's called benign ethnic neutropenia. If you don't know that, you might launch a huge unnecessary investigation for a blood disorder that isn't there.
In pregnancy, you said that just throws all the reference ranges out the window.
It's a physiological storm. Urea and creatinine go down, alkaline phosphatase goes up because the placenta makes it, and critically, D-dimer goes up.
The blood clot marker.
Right. It's a normal physiological change in pregnancy. So a raised D-dimer in a pregnant woman can be totally normal. If you don't know the context, you're sending her for a needless, expensive, and potentially risky scan.
And then there are just errors in the test tube itself. Spurious results.
Pseudohyperkalemia, falsely high potassium. This happens if the blood cells burst in the tube after the sample is drawn. The potassium leaks out in the tube, not in the patient's body.
So the patient is fine, the sample is bad.
Exactly. A good clinician always checks for hemolysis on the lab report when they see a high potassium that doesn't fit the clinical picture.
Okay, and then we have to think about the test itself, the operating characteristics, how it's actually performed.
This could be anything from the patient not being able to follow breathing instructions for a lung function test to the skill of the sonographer doing an ultrasound.
And the big pitfall here is calling a poor quality test normal.
Yes. If an ultrasound of the liver was technically difficult because of the patient's body shape, the report shouldn't say no abnormality detected. It should say non-diagnostic. That's a huge difference.
This all loops back to the idea that the history is primary, especially with paroxysmal conditions, things that come and go.
Absolutely. Think about epilepsy. Yeah. About half of people with real epilepsy will have a completely normal EEG test. So a normal test doesn't rule it out.
And the flip side?
The flip side is that about 10% of people without epilepsy will have abnormal epileptiform discharges on their EEG. The lesson is non-negotiable. Test results must always be interpreted in the context of the history. They are a supplement, not a substitute.
Okay, let's move to the bedrock of test statistics, sensitivity and specificity.
A quality metrics of the test itself.
So sensitivity.
Sensitivity is the ability of a test to find the true positives. It's the proportion of people with the disease who correctly test positive.
But even a 95% sensitive test will miss 1 in 20 people who have the disease.
And we have to anchor on that. Even good tests produce false negatives. They miss people.
And specificity is the other side of that coin.
Specificity is the ability to find the true negatives. The proportion of people without the disease who correctly test negative. The higher the specificity, the less likely you are to get a false positive.
The crucial problem, though, is the trade-off between them. You can't have 100% of both.
That's the trade-off. You're always balancing them. Clinicians choose where to set the cutoff point for a test, depending on what they're trying to achieve.
Let's use the exercise ECG for coronary artery disease again.
Okay, so if you set a very low bar for an abnormal result, say just 0.5 millimeters of ST depression, you'll catch almost everyone with the disease. You'll have very high sensitivity.
But you'll get a ton of false positives.
A ton. Low specificity. But if you raise the bar to 2.0 millimeters of ST depression,
Now you have high specificity. If that test is positive, you're very confident the person has the disease.
but you pay for it with lower sensitivity. You'll miss a lot of people with milder disease. You're choosing between false negatives and false positives.
And this choice leads directly to those crucial mnemonics.
You need these locked in your brain. A highly sensitive test, when it's negative, helps to rule all UT, the disease. SAUT.
Use a CESNU test when missing the disease would be a catastrophe.
Right. And conversely, a highly specific test, when it's positive, helps to rule in the disease. SPIN.
Use a spin test when you need to be sure before starting a risky treatment.
That's it. SAU and SPIN.
Okay, so we've established this idea that how you interpret new information depends entirely on what you believed before you got it. And the engine that powers that update is Bayes' theorem.
Right. Conditional probability. And doctors aren't doing the math at the bedside, but they're constantly running a conceptual version of it in their heads.
It's the engine of the OS.
It is. It's how you combine your pre-test probability, your initial belief, with the test characteristics, the sensitivity and specificity to get to your post-test probability, your updated belief.
Let's make this concrete with the hip fracture example. It shows how the exact same test result can mean totally different things.
Perfect. So 2 patients, both with hip pain, both get a standard X-ray, which is about 95% sensitive.
Patient A, high pre-test probability. An elderly, frail woman with known osteoporosis. After a fall, she cannot bear any weight at all. Her X-ray comes back normal.
So because the test is only 95% sensitive, there's a 5% chance it's a false negative. If your pre-test probability was 70%, a normal X-ray might lower it, but she still has a very significant chance of having a fracture.
So the normal X-ray does not rule it out. You need more imaging.
You need an MRI. Now contrast that with patient B. Low pretest probability. A young, healthy person can bear some weight, no major risk factors. Their X-ray is also normal.
In this case, the pretest probability was maybe 5%?
So that 95% sensitive normal X-ray drops that probability to almost 0. In this case, the normal X-ray effectively and reliably excludes the diagnosis.
It's the same test, same result, totally different meaning.
It all comes down to that profound principle from Sachs and colleagues. The interpretation of new information depends on what you believed beforehand.
And to get that initial belief right, we need to anchor it to something. That anchor is the prevalence of the disease.
The base rate.
Which leads us to that brain-bending statistical illusion, the Harvard doctor's problem.
Get ready, because this is where human intuition just completely falls apart.
Okay, let's lay it out for you listening. There's a disease, and its prevalence is 1 in 1,000. The test for it is excellent, with a false positive rate of only 5%. For now, let's just assume it's 100% sensitive, so no false negatives.
Okay.
A person tests positive. What is the chance they actually have the disease?
And just take a second. Listen to your gut. Most people, even experienced doctors, their brain just leaps to 95%. They see that 5% false positive rate and they think, wow, 95% accurate.
But they're forgetting how rare the disease is.
They're forgetting the base rate. So let's do the math. Imagine 1,000 people.
Okay.
Out of those 1,000 people, only one person actually has the disease. That's your one true positive.
Right. And you have 999 healthy people.
And the test has a 5% false positive rate. So 5% of those 999 healthy people will test positive by mistake. That's about 50 people, 50 false positives.
So the total number of people who test positive is 1 plus 50, 51 people.
Right. So what's the chance that a person with a positive test actually has the disease? It's 1 out of 51.
Which is about 2%.
2%, not 95. Your intuition was spectacularly wrong because the rarity of the disease completely overwhelmed the specificity of the test. That is base rate neglect.
The ultimate cautionary tale.
Yeah.
And this is what brings us to predictive values.
Right. Positive and negative predictive values, PPV and NPV, are measures that already have the prevalence baked into the calculation.
PPV is the proportion of positive tests that are true positives.
But here's the key distinction, and you have to get this right. Sensitivity and specificity describe the test itself. They are fixed characteristics.
And they don't change no matter who you test.
Exactly. But predictive values are totally dependent on the population. As the Harvard problem shows, if you change the prevalence, you totally change the PPV. So you can't take a PPV from a specialist clinic and apply it in general practice where the prevalence is way lower.
So the doctor's job is to use their judgment to estimate the pretest probability for their individual patient, and that has to be anchored on the base rate for that patient's group.
You anchor on the prevalence, then you adjust up or down based on the specific patient in front of you. That's the art.
Okay, time for our second check-in, chicken 2, the statistics. Here's the question for you. Which value describes the test itself, regardless of the population? Is it sensitivity or is it positive predictive value?
If you said positive predictive value, please rewind. That is incorrect. PPV depends on prevalence. Sensitivity and specificity are the stable characteristics of the test.
All right, we've established that the data is uncertain. So how does a doctor actually decide when to act? Let's talk about the treatment threshold.
This is so practical. You almost never have 100% certainty when you make a decision. The key idea is that the amount of certainty you need depends on the penalty for being wrong.
So low penalty, low threshold.
Exactly. If you're thinking about prescribing simple antibiotics for a suspected UTI, the treatment is effective and very low risk. You don't need to be 99% sure. 70% might be enough to act.
But if you're thinking about starting chemotherapy,
the penalty for being wrong is huge. The treatment is toxic, so you need a much, much higher level of diagnostic confidence before you pull that trigger.
A good rule of thumb here is if a test isn't going to change what you do, maybe you shouldn't do the test.
A very important point.
Before we even get to testing, though, we need to talk about how experts organize all that messy initial information. Problem representation.
This is a huge difference between how novices and experts think. A student will hear the story and immediately jump to a list of possible diagnoses.
Right, the differential diagnosis.
But an expert spends way more time just defining the problem first. They synthesize all the data, the age, the symptoms, the risk factors, the timeline into one precise medical statement.
Give me an example of that.
Okay, so instead of a man with breathing difficulties, an expert's problem representation would be a 65-year-old male with a 40-pack years smoking history presenting with acute onset, progressive shortness of breath, and finger clubbing.
That's so much more specific. Why is that so powerful?
Because that precise statement immediately activates the right files in your long-term memory, what we call illness scripts. It brings the most likely and the most dangerous possibilities straight to the front of your mind. The vague statement doesn't do that. You risk missing things.
Now we have to face it. The human OS, our brain, is brilliant, but it's also flawed. Let's talk about cognitive biases, and let's start with that bat and ball puzzle.
Yes. Okay, here it is again. A bat and a ball cost £1.10 in total. The bat costs £1 more than the ball. How much does the ball cost?
And the answer that just pops into your head is 10p. It's immediate, it feels right, and it requires zero effort. But it's wrong.
It's wrong. The correct answer is 5p. But to get there, you have to stop, engage your brain, and do the math. That intuitive leap versus the slow calculation, that's the heart of dual process theory.
We have two modes of thinking, type 1 and type 2.
Right. Type 1 is the autopilot. It's fast, intuitive, automatic. It's pattern recognition. We use it 95% of the time. It's great for recognizing a classic case of the flu, but it's very vulnerable to error when things are complex.
And type 2 is the manual override?
That's the slow, analytical, deliberate thinking. It takes a lot of effort. It's systematic. It's what you use to solve a difficult problem or, crucially, to check the work of the type 1 autopilot.
And errors happen when we use the autopilot in the wrong situation or when our manual override is just too tired to work.
Exactly. So imagine a patient comes in with a classic chest infection. Type 1 recognizes the pattern instantly. Diagnosis, treatment, efficient and correct.
But what if the case is a bit strange?
Then type 1 might still offer up the most familiar diagnosis just because it's easy. A rational override is when you deliberately engage type 2. You stop and ask, wait a minute, what's the evidence here? What else could this be?
So what's an irrational override?
That's when you do the opposite. You've done your type 2 work, you've used a guideline, and you've decided the patient is safe to go home. But then a very senior colleague walks past, glances at the patient, and says, "Ooh, they look a bit unwell, I'd admit them." And you override your evidence-based decision with their type 1 gut feeling.
In these failures of our OS, these are the cognitive biases. Let's run through the big ones with clinical examples. First up, anchoring.
Anchoring is when you over-rely on the very first piece of information you get. So the paramedics bring in a confused patient and say, "We think it's a drug overdose."
You anchor to that idea.
You anchor to it. So when a lab test comes back showing a slightly low sodium, you dismiss it. You explain it away as part of the overdose picture instead of properly investigating it as the real cause of the confusion. The anchor was too strong.
And once that anchor is set, it can lead to diagnostic momentum.
This is so dangerous. A label gets attached to a patient, and it just gathers speed as they move through the hospital. The first doctor writes, "non-specific abdominal pain." The next doctor reads that and accepts it without going back to square one and properly re-examining the patient.
And that often starts with premature closure.
Yes, you stop the thinking process too early. You find an answer that seems to fit, and you just stop looking. It's often linked to search satisficing. You find one thing wrong, and you stop searching for a second, more serious thing.
Then there's confirmation bias.
This is when you only look for evidence that supports your theory, and you ignore anything that contradicts it. If you think a patient has an autoimmune disease, you'll focus on the one slightly raised inflammatory marker and ignore the 5 other tests that are completely normal.
And the psych out error. This one feels particularly awful.
It's a devastating bias. It's when you under-investigate a medical problem in a patient who has a known psychiatric condition. You just assume their new symptom is all in their head.
So the patient with schizophrenia complaining of chest pain gets told it's anxiety.
And they're having a massive heart attack that gets missed. They are denied the proper type 2 analysis because of a label.
And finally, the one we saw with the Harvard problem, base rate neglect.
Ignoring the actual prevalence of a disease, a patient has a headache, and you've just been reading about a rare brain tumor, so that's the first thing you think of. You're neglecting the fact that the base rate for a headache being something benign is astronomically high.
So if these biases are just part of being human, we need actual strategies to fight them. First up, metacognition. Thinking about thinking.
This is your #1 defense mechanism. It's being consciously aware of your own thought process. It's the act of forcing your type 1 autopilot to submit to a type 2 review. And studies show it dramatically improves your diagnostic accuracy.
How do you do that in a busy clinic?
It can be as simple as asking 2 questions. When that first intuitive diagnosis pops into your head, you stop and ask, what is the evidence for this? And what else could this be? What's the worst case scenario I cannot miss?
That forces the interruption.
It forces you to switch from type 1 to type 2, and that's what expertise really is. It's having the knowledge, yes, but it's also having that built-in reliable ability to stop and think when you need to.
It's not just about us, though. The environment matters. Human factor science.
Yes. We have to design systems that account for human limitations. The parts of our brain needed for that effortful type 2 thinking are massively impaired by things like fatigue, stress, and cognitive overload.
So when you're exhausted, your brain just defaults to the error-prone type 1 autopilot.
It has to. It's a survival mechanism. That's why safe working hours and well-designed workflows are patient safety issues, not just staff wellness issues.
The book also mentions a paradox about focus, that being too focused can be dangerous.
Right, selective attention. When you're focusing really hard on one thing, you become blind to unexpected things happening in your peripheral vision. You only see what you're looking for. This is why team communication is so vital.
Someone else might see the thing you missed.
Exactly. But they have to feel safe to speak up. Strict hierarchies are dangerous. Everyone on the team needs to feel empowered to verbalize key information, which is why we have tools like SBAR.
Situation, background, assessment, recommendation.
It's a structured way to communicate that cuts through the noise and ambiguity, especially during a stressful handover. It forces type 2 clarity in a type 1 chaotic environment.
Beyond self-reflection, we have tools to help us think better. Clinical prediction roles or CPRs.
Things like the Wells score or CURB-65, they're statistical models that help you estimate probability more accurately and consistently. They often outperform expert opinion because they don't have biases. They just use the data.
They're a direct antidote to base rate neglect.
Absolutely. Then we have explicit cognitive debiasing strategies. First, deliberate practice. It's not enough to just see lots of patients. You need coaching and feedback to get better.
Second, The unpacking principle.
This means you make sure you've collected all the information, especially from other sources like family or caregivers. You unpack the whole story, not just the bit the patient tells you.
Third, using mnemonics and checklists.
This just reduces your reliance on fallible human memory. The ABCDE approach for a critically ill patient is the most successful checklist in medicine. It stops you from getting distracted and missing a life threat.
And finally, a strategy called ROUSE, rule out worst-case scenario.
This is deliberate metacognitive strategy. It forces you to consider the low-probability, high-consequence diseases. When a patient has pleuritic chest pain, you use ROUSE to force yourself to consider a pulmonary embolism. Even if you think it's just a pulled muscle, it's a forced type 2 check.
Okay, this is the moment. Let's put it all together with the PE case study from the book.
Let's do it.
The scenario: a 25-year-old woman. She has right-sided pleuritic chest pain and breathlessness. Her vitals are normal, exams normal. The key piece of information: she's on the combined oral contraceptive pill. The question: does she have a deadly pulmonary embolism?
Okay. Step 1. Pre-test probability. Her symptoms are nonspecific. A normal exam tells us nothing. We have to anchor on the base rate.
The prevalence of PE in a healthy 25-year-old is very low, but the pill is a risk factor.
So we use the CPR, the modified Wells score. She only scores 3 points, which puts her firmly in the low probability category, maybe a 5% chance of PE.
Step 2, interpreting the test. We do a D-dimer test. It comes back high at 900. Normal is less than 500.
Now, this is where the biases kick in. You see a high number, you know she's on the pill, you start to anchor on the idea of a PE.
Right, the alarm bells start ringing.
But you have to use your rational override. The D-dimer is a highly sensitive SNOU test. If it were negative, we could rule out PE. But it has terrible specificity.
It can be raised by lots of other things. Her recent cold, inflammation.
Exactly. So in a low probability patient, a positive D-dimer does not confirm PE. It just raises the probability from 5% to maybe 15 or 20%. All it tells you is that you can't exclude PE yet.
Step 3, treatment threshold and ROUSE stance. PE is a worst-case scenario. The penalty for missing it is death. The risk of treating her with blood thinners for a short time while we get a definitive scan is pretty low.
So the decision is made. The threshold for acting as if she has the disease is low. We start treatment while we wait for the high-specificity SPIN test, the CT scan.
Step 4, post-test probability. The CT scan comes back, no pulmonary embolism.
Now use SPIN. The highly specific negative scan, combined with her low pretest probability, now reliably excludes the diagnosis. We can stop the treatment.
Step 5, reviewing the biases. Imagine the handover was different. Imagine the triage nurse had said, oh, it's just a pulled muscle, she's anxious.
You'd be instantly vulnerable to the framing effect. You'd be looking for evidence to confirm pulled muscle confirmation bias, and you'd probably stop there. Premature closure. You'd never even do the Wells score. It's a cascade of errors.
Step 6, shared decision-making. So, you tell the patient.
You explain that the final diagnosis is most likely viral pleurisy, and you explain the process you went through to rule out the dangerous alternative. And critically, you give clear safety netting advice. You tell her exactly when to come back if things get worse.
Okay, final check-in for you listening. Check-in 3, synthesis. Think back to those human factors. If you saw this patient at 3 a.m., totally exhausted, which 2 internal factors and which cognitive bias would make you most likely to make a mistake and send her home?
The internal factors would be fatigue and sleep deprivation, and the bias would most likely be premature closure. Recognizing your own vulnerability in those situations is the absolute key to being a safe doctor.
We have completed our deep dive into the physician's OS. We anchored the idea of likelihood ratios on that seesaw metaphor. We nailed down the difference between sensitivity, SNOU, and specificity, SPON.
And we exposed that great trap of the Harvard doctor problem, showing how crucial it is not to neglect the base rate, the prevalence of a disease.
We saw how our fast, type 1 thinking, while efficient, is vulnerable to a whole host of biases, which get worse when we're tired and stressed. And the ultimate defense is metacognition and using tools like CPRs and ROUSE to force that slow, deliberate type 2 check.
That's the whole thing in a nutshell. The most important skill isn't just knowing things, it's knowing when to stop and think.
And so, we'll leave you with our final provocative thought. We've learned that you often have to act as if a disease is present, even without total certainty. Given that a doctor's ability to do that hard, type 2 thinking is a limited resource that gets depleted by fatigue and stress, how do our medical systems need to evolve? How can we use technology, maybe AI, to ensure that that critical analytical thinking is always available, even when the human brain operating it is compromised?
The future is going to be about that symbiosis. The brilliant but fallible human OS working together with systems designed to catch our predictable errors. That's what's going to define the next 100 years of medicine.
Until next time, stay curious and keep diving deep.